All right, welcome everybody. Let's get started. My name is Scott Larsen, and I'm a chiropractor here at the Institute for Health and Healing. I work in the San Francisco clinic, and it's great to be with you all today. We're going to be covering a huge topic that's the most important topic I could think of to deliver to you today, and we probably need to talk about this again and again and again. And the goal for today is to get educated and then to learn how to make good decisions for yourself around this subject, and hopefully you can spread the message. You can share the good news with everybody you come in contact who has this problem, because low back pain is what we're going to be covering. And low back pain is like the leading cause of disability and musculoskeletal pain in the world. It's increasing across all ages, all countries. Their low back pain numbers are going up. The cost is huge, staggering. My practice every day. This is my basically my life, and so I'm going to be coming at this from an angle. You got to know I'm a chiropractor. My bias is chiropractic and how I was trained, and I acknowledge my biases. I embrace them, but I'm going to be coming at you from a general health standpoint and trying to present you from not what I've experienced in clinically, which I think is relevant, but from an angle of what the literature is saying, what systematic big time reviews and systematic reviews and compiling randomized controlled trials and other gold standard studies and case examples and all kinds of things. That's what I want to present to you. So that's where I'm coming from, but my biases will probably sneak in, so just forgive me for that. All right, so how do you understand and navigate low back pain? Like I said, this is one of the world's biggest problems. And so we're going to try and solve it today here on a Friday afternoon. Just kidding. Okay, so in March 2018, The Lancet, which is a renowned medical journal, published a series on low back pain. And if you are interested, that's where I'm getting my information from, because up to that point, we were using other guidelines, a variety of guidelines from different medical associations and journals and committees that got together. But now most people are trying to get caught up on the Lancet low back pain guidelines. So that's what we're going to be covering. I think they're awesome. So low back pain is super common. It occurs in high-income countries, middle-income countries, low-income countries, from kids to adults to elderly populations. It doesn't matter who you are, you can get affected by this. And like I said, it's the leading cause of disability worldwide. And in a small, tiny little sliver of the population, when you look at a pie chart of what might be causing your low back pain, only a small population have an understood pathological reason, like a fracture of the vertebrae or malignancy or an infection or other pathologic inflammatory condition. For nearly almost, I would say 95% of the rest of the cases of low back pain in the world, there's not a specific nociceptive cause. We don't know what's causing your pain. This is my bias, we may think we know, and it seems perfectly logical, but from specialty to specialty to specialty, you're going to get different answers. One ologist is going to tell you one thing, the chiropractor is going to tell you another, the physical therapist is going to tell you another, your massage therapist is going to tell you another, and it's all across the board, and maybe everybody's right in a little way, or maybe we're all kind of missing the boat. So there's not a specific cause for your low back pain. So people with demanding jobs, people with physical and mental conditions, people who smoke, people whose weight is above 25 on the BMI scale, those individuals are at more risk for reporting low back pain. But that's not, the whole full story. You can have low back pain if you don't smoke, if your BMI is in the normal range, if you don't have an associated physical or mental distress condition. So the cost, the healthcare, the disability, it's substantial. So let's continue on. The recommendations to rest when you have no back pain, regardless of the severity, is not good. Depending on what country you live in and across the world, you're probably going to hear the old way of thinking about this, which is not yet changed, is to rest when you have low back pain. In the United States, that's still true. Surveys still go out to primary care practitioners or internal medicine or family medicine, or even, my profession is guilty of this, is to rest and don't resume activity until your back pain has gone away. And that's because a lot of the natural course of back pain lasts 4 to 6 weeks, goes away on its own. You don't need any intervention. So they say, okay, rest for a month and then go back to work, or then go back to riding your bike, or then go back to the gym. That's not recommended. That's counter recommended. We want to do the opposite. You want to get active as soon as possible. And you want to look at the whole person. You're not your disc herniation. You're not your facet arthritis. You're not your spinal tendinitis. You're not your muscle spasm. It's the biology, it's the psychology, and it's the social aspects of your issues that cause low back pain. So you have to look at the whole person. You have to treat the whole person. You don't have a bad back, okay? It's all the factors of the biology, the psychology, and all the social factors combine to give you your experience in back pain. And like I said, some lifestyle factors are correlated with poor outcomes, but that's not always the case, and so it's really tricky. But you can control some of it. So there are potential nociceptive contributors, or what I mean is there are structures in the low back that have pain fibers attached to them that can cause back pain, and you gotta look at that. That's the biology, okay? So there's discs, there's facet joints, you have cartilage on the end plates of your vertebral bodies, you have muscles, you have fascia, you have tendons, you can have trigger points, you can have muscle guarding, the lymphatic system can play a role. You have inflammatory chemicals that can sit around a nerve root, around a muscle, and these can all turn on the nociceptive system, which is the pain system, which I talked about a couple of talks ago, which I would refer you back to that. But so you can turn on the nerves that sends pain to the brain, you register the pain, and you have pain, okay? But you can also have nerve roots that get involved. And so with the little nerves that branch out from the spine and come out of from your spine, those nerve roots can get irritated. And we call that radicular pain or radiculopathy. That's when the nerve root's involved. Usually that pain is in the leg. It's worse when, like, you're coughing, you're sneezing, you're straining. There's a couple orthopedic tests you can do. You can do a straight leg raise, for example, to check and see if you may have a nerve root that's involved. You may have loss of sensation in your legs, loss of reflexes in your legs that point to a particular nerve root. And that could be the cause of your back pain. People who have low back pain and radicular leg pain or radiculopathy tend to experience poorer outcomes than people with just the low back pain. Like I said, like a structure in your low back, a disc, a muscle, a facet joint. If you just have that, you might have better outcomes. If you have the low back and the leg pain, you could potentially have worse outcomes. But here's the kicker. They've done this over and over again. They've done imaging studies on disc herniations, on disc bulges, to look for nerve root involvement. And there's people walking around right now, and you're probably one of those people potentially who has a disc herniation that's not painful, that may even look like on image, an imaging study like an MRI, that is pressing on a nerve, and there should be some sort of nerve root activation, but there's none. So you can't predict your back pain based on the imaging studies that are currently being done in the medical context. You could have a spinal stenosis. So this is a cause of potential back pain, and that's where the spine inside the canal, where the spinal cord lives, you can have some of the ligaments can get big. And usually you'll have some sort of bilateral leg pain that's irritated with activity or prolonged standing, and that's usually done and evaluated on imaging. So those are some of the reasons for back pain. There's structures involved that can cause nociceptive-based pain, but imaging doesn't correlate to the pain. It's not something that is clearly understood. And doesn't need medical intervention for most of the things. Like I said, if you have a fracture, if you fell on your back, if you have an inflammatory condition, if you have a malignancy or a cancer or an infection. Those are causes for immediate medical intervention, but they don't necessarily, if you have low back pain, you don't necessarily need medical intervention. So let's get down to the kind of the brass tacks of what potentially could cause a scenario where you experience back pain that becomes more frequent, recurrent, worse over time, leading to disability, leading to a poor quality of life, leading to you not doing what you love. So as I go off this list, I want you to maybe even write down what pertains to you. And you may have 2 or 3, 4 things on this list, and those are the things for you to get over your back pain that you have to start working on, or at least thinking about. So one of the predictors is, how many times have you had episodes of back pain? The more episodes you have, the more potential you have for a poor outcome and a chronic disabling pain. How intense is your back pain? Do you have a low level intensity, or do you have a high intensity? Would you rate it on a high scale, like a 7, 8, 9, 10 out of 10 on the pain scale? If you are, your risk of having a problem and a disabling problem increases a lot. Like I said, do you have leg pain? If the leg pain is present, your risk factors for having disabling back pain that's going to ruin your life goes up a lot. Lifestyle factors. Do you have a body mass that's over 25? Do you even know what your body mass is? A body mass is a calculation of several things that gives you a number. The range that the medicine wants you to be in is about 18 to 25. Everyone's a little different. We have different body types and such. But if you have a body mass of 25 or greater, you could work on that to increase your chances of having a good outcome. Are you smoking? People who smoke can develop chronic disabling back pain if they're smoking. It's tied together. And then physical activity. Only 18% of people who live, and that's generous, but I would think only 18% of people who live in the United States perform exercise or complete the physical activity guidelines set forth by the American College of Sports Medicine. If you're sedentary, if you're not active, your chances of having disability associated with your back pain greatly increase. Psychological factors. These are lifestyle factors: your body mass, smoking, and physical activity. Psychological factors. If you have these factors, your chance of having disabling back pain increases. One is depression. People with depression have mixed outcomes. They are tied to significant poor outcomes in a lot of cases. Catastrophizing. Catastrophizing you can define catastrophizing as someone who assumes that the worst is going to happen. And it's a belief system that you're basically in a worse situation than you really are. And if you are somebody and it's not a slight, I'm not beating you up. If you are a person who catastrophizes your back pain, your chances of having a disability related to that back pain increase. And this is based on dozens of studies. Fear avoidance beliefs. This is one of my favorite ones. Your back pain changes your belief system, and you basically tell a story about your back pain. You stay at home because of your back pain. You avoid doing things in your life that you may not even be aware of. You may not stand because of your back pain, and you may not even be thinking that you're not standing because of your back pain, but you basically start avoiding things because you're afraid that your pain will either get worse or not resolved because of your activity level. Social factors, and then we'll get to the next point. If there's things in your life you're doing that are physical loads on the back, like strenuous lifting, working in an environment where you're pushing and pulling and lifting heavy loads in awkward positions, your chance of disability goes up. If you're poorly educated about back pain specifically, but also related to college education, your risk goes up. If you get paid for your back pain, your risk is going to go way up. So compensation, workers' compensation, other forms of disability payments related to back pain increase your chance of permanent disability. And this is my favorite one. Work satisfaction. If you hate your job, if you don't like your job, if there's major aspects of your job that you hate, your chances of having chronic disabling back pain increases dramatically. All right. So we talked about this before, but there's this whole central pain model that you can look at. basically a stimulus to a painful area increases over time because your central nervous system starts to become sensitized to that like stimulus. And so what may have been like, so you push into your leg that's sore 5 years ago, and it's like mild, one out of 10 on the pain scale. Over time, if that pain could persist, you become really, really adept at monitoring that pain, and the same pressure, the same PSI, the same stimulus, all of a sudden becomes much more painful. And so you can develop these chronic central pain models that are very hard to break, and we discussed that before. So prevention is a worthy goal, but it's not easy. And there's not a lot of science-based things, and this is important to understand. So the best prevention for back pain and low back pain having good outcomes is being educated on low back pain and staying active. If you remember nothing from today, you got to get educated about back pain. And you got to educate yourself on the biopsychosocial model. You don't need to educate yourself on the pathophysiology of a disc herniation, a grade 2 disc herniation pushing on L4. That's not important. What you need to understand is what's your biology, how does it relate, what could be causing pain. That's all you need to know. What factors socially and what factors psychologically are being changed. That's the education piece. And then staying active through the whole time you have back pain is critical. So ergonomic furniture, mattresses, back belts, lifting devices, insoles for your feet, having a standing desk. I could go on, but those prevention strategies don't have a lot of science behind them. They can work, but there's not a lot of quality evidence that show that they prevent long-term chronic back pain. So you have back pain. You're trying to figure it out. You want to treat it. You go to the doctor. The doctor of today, of 2020, of the coming decades, it should use the biopsychosocial model of treating your back pain regardless of severity. Once they rule out fractures and malignancies and infections and other inflammatory conditions that need to be intervened by the medical approach, if that's ruled out, you don't want to get drugs. You don't want to get surgery. Those things do not have good evidence behind them. The evidence is get educated by your provider and then get active as quickly as possible. Depending on your country, you're going to get different advice. In the US, most of the activity that you're going to get is yoga, based on all the recent surveys. The best advice that your doctor could probably give you is to do yoga. The other things you could do are Tai Chi, massage, acupuncture. You could see the chiropractor for an adjustment or spinal manipulation, and then physical therapy, occupational therapy. Those are interventions that are like second tier. So the first tier is education, activity. Second tier will be some sort of modality that you can apply to the back to try and improve your situation, your level of comfort, the ability to move throughout the day. Is highly tied to people helping you, a team of people working on you for a short period of time. I touched on it, but non-steroidal anti-inflammatory drugs, muscle relaxers, these are second line options that your primary care practitioner, your family medicine person, your internal medicine, so people you go to and complain of back pain. The second tier is drugs, which means get active, understand your back pain first. And then if you want to do a pharmaceutical intervention, that's the second line approach. In the second tier category, you have spinal manipulation, massage, yoga, acupuncture, the mindfulness-based work, meditation, those types of things. Opioids are highly controversial. We're not going to touch on opioids too much. We all know about the opioid crisis. They're appropriate in some patients, and you have to proceed with caution, definitely. That's not my realm. That's not my specialty. I don't talk about that in any detail, but it is relevant. And then, you have epidural, glucocorticoid injections or cortisone injections into areas that have, pain, radiculopathy, herniated discs, and those are appropriate in very select patients. Surgeries, you can get discectomies, laminectomies, you can get fusions. There's other types of surgeries. Those are in highly select patients who have tried other approaches. There's some level of warrant there, but it's not a first line approach. Other things in the treatment category: ultrasound, TENS units, the transcutaneous nerve stimulators, traction, interferential therapy, back supports, like I said, insoles, standing desks. There's not a lot of evidence to support, getting you out of pain and improving your quality of life. So you're not your disc, okay? You're not your sciatica. You're not your arthritis. You don't have a bad back for most people. You're a whole person. You have to look at all of your behaviors. Let me touch on this really quick, and then I'm going to open up for questions. Hold on. So I read through this list at one of my talks, but I'm going to read through some of it again because this is so critically important to me. Ask yourself if this is you. I stay at home because of my back. I change positions to get comfortable because of my back. I walk slowly because of my back. Because of my back, I don't do jobs around the house. Because of my back, I use a handrail. Because of my back, I don't lie down. Because of my back, I'm told I can't get out of a chair, or I can't get out of a chair easily. The list goes on and on. Because of your back, you don't bend down. Because of your back, you don't twist. Maybe somebody told you shouldn't twist. Maybe somebody told you shouldn't bend down. These things constrict you, and your decision making around how to get active become really limited, and you may not even know you're doing these things. Your appetite changes because of your back pain. You can't put on your pants or your socks or your underwear because of your back pain. Because of your back pain, you can't get in and out of the bathtub or in and out of the shower without help. Maybe you're aggravated, ill-tempered. People don't want to be around you because of your back pain. This stuff changes your whole life, and you can experience this whole new emergence of having a poor quality of life tied to your back pain with chronic disability if you're not careful. So that's my message for today. Get active. There's no secret solution. There's no magic treatment approach that you just are missing. You have to get active, and you have to remain active. That will build confidence. So when you move, when you're educated about your back pain, you get confident. You're able to move and know that there's not going to be a catastrophic event. You don't have a weak back. Humans haven't evolved to a place right now where their spines are so fragile that we can't bend down and pick stuff up when we have a sore back. You got to be careful with the imaging aspect. It can create a narrative that turns yourself into this. I am my disc. I am an L5 herniation with facet arthropathy and blah, 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 blah. You got to be careful when you look at these images and your story starts to be honed in, and it's hard to break those patterns once they're in, and they do affect you. The first line of therapy should be a non-pharmacological approach. So exercise, massage, yoga, tai chi, chiropractic, physical therapy, those types of approaches should be the first line therapy when you're experiencing back pain. And then exercise is recommended for everybody who has chronic low back pain. And the degree to how much you exercise is going to change, depending on who you are, what your comorbidities are, who you are, what your past traumas are. That's where the fine-tuning detail come into play. And that's the most fun aspect I have of my practice, is helping educate people about their specific personal situation, and then helping them create a plan to help to navigate themselves out of this chronic pain.